Assalamu alaikum. This lecture will be about shoulder dystocia. Lecture objectives: to know the individual risk factors for shoulder dystocia and their relative importance, to be able to advise a woman antenatally about the risk of shoulder dystocia in her current pregnancy, to recognize a labor at risk of shoulder dystocia, to be able rapidly to recognize shoulder dystocia and have a clear plan of management for shoulder dystocia. Definition: is an obstetric emergency, defined as vaginal cephalic delivery that require additional obstetric maneuvers to deliver the fetus after the head has delivered, and gentle traction has been accessible in delivering the shoulders. There is many definitions of shoulder dystocia. This is first. Shoulder dystocia, as we know, they occur in vaginal cephalic delivery. After delivery of the head, there is restitution and external rotation to be the shoulders in anterior-posterior diameter instead of oblique diameter, aligned anterior-posterior, and there is anterior shoulder and posterior shoulder. Shoulders and trunk fail to be delivered by gentle axial traction and need additional obstetric maneuver. This is called shoulder dystocia. Other definition: it's head to body delivery time interval of 60 seconds or greater. 60 seconds is required for restitution and external rotation and delivery of the fetal trunk. Any delay at this step, this is diagnosed as shoulder dystocia. So, one of the definitions of shoulder dystocia is upon impaction. Upon impaction between anterior shoulder and symphysis pubis. Rarely occur to posterior shoulder, but commonly it's anterior shoulder with symphysis pubis. So it's upon impaction, not soft tissue. Etiology: as the fetal head passes through the pelvic outlet, the shoulders simultaneously enter the pelvic inlet. As restitution of the fetal head occurs, the shoulders rotate through the pelvis, and the anterior shoulder present under symphysis pubis will be aligned in anterior-posterior diameter. In cases of true shoulder dystocia, either anterior shoulder or in CV form, both anterior and posterior shoulders are arrested at pelvic inlet. So it's upon impaction at level of pelvic inlet and symphysis pubis. Incidence: shoulder dystocia occurs when either anterior or posterior shoulder impact on maternal symphysis or the sacral promontory respectively. Anterior shoulder with symphysis pubis and posterior shoulder with sacral promontory. Overall incidence is 0.2 to 1%. Risk factors: there is antenatal risk factor and intrapartum. Intrapartum or labor-related risk factors as assisted vaginal delivery with forceps or vacuum and male with vacuum. There is no time for mechanics of labor to be occurred during assisted delivery. Labor dystocia and prolonged second stage of labor. Antenatal risk factors: prior history of shoulder dystocia, and there is recurrence, high risk of recurrence, gestation or pre-existing diabetes. In diabetes, there is a macrosomic babies, and macrosomia is a known risk factor for shoulder dystocia. Male fetal sex by sacrum diameter in male sex more than female sex. Maternal obesity, excessive weight gain during pregnancy, post-death pregnancy. In post-death, there is fetal gain weight and will be macrosomic. And post-death is a risk for macrosomia. Abnormal pelvic anatomy and short stature is pelvic cause. Complications: there is fetal and maternal. Fetal complication: asphyxia and brachial plexus injury, humerus fracture and clavicle fracture. Prenatal morbidity and mortality are high. Maternal: postpartum hemorrhage and soft tissue injury, example cervical tear, vaginal lacerations due to manipulation, and third and fourth perineal tear, even rupture uterus. Sacroiliac joint dislocation and morbidity. We talk about obstetric brachial plexus injury. Mitigation in shoulder dystocia occur due to brachial plexus injury. So, obstetric brachial plexus injury: either the nerve root or trunk of the brachial plexus are involved, as the trunk or nerve roots. The damage of the nerve due to stretch, which is commonest, or avulsion or hemorrhage inside the sheath. Tearing of the fibers is rare. It's palsy, brachial palsy, not injury. Although most newborns recover 6 to 12 months, up to 20% will have some degree of permanent injury. It's reversible, but 20% have permanent injury. There is two types of brachial nerve palsy. Ehlers palsy is the most common type when 5, 6, and 7. The resulting paralysis causes the arm to lie on the side, abducted arm, with extension of the elbow and pronation of the forearm, with flexion of the wrist, which is called waiter stick. Its characteristic. Motor reflex is absent. Motor reflex, one of the primitive reflex after delivery. When you drop the fetal head, there will be abduction of the both arm. This will be absent due to Ehlers palsy and most probably unilateral. They may be associated ipsilateral phrenic nerve, diaphragmatic paralysis in C3, 4, and 5. Ehlers palsy is mainly C5, 6, and maybe 7. Might be ipsilateral phrenic nerve as C3, 4, and 5. This image illustrates Ehlers palsy and Klumpke's palsy. Differentiate between them. Both of them are brachial plexus palsy. One of them Ehlers palsy, upper trunk injury, and the other lower trunk injury. In Ehlers palsy, C5 and 6 involved and will be characteristic waiter step postures اللي هي adducted arm, extended and pronated forearm with flexed wrist. In Klumpke's palsy, this type of palsy is due to affection of the lower cord of the plexus involving 7th, 8th, cervical, or even the first thoracic nerve root. There is paralysis of the muscle of the forearm. The arm is flexed at elbow and the wrist is extended. The forearm is supinated and claw-like deformity of the hand is observed. When the first thoracic nerve is involved, will be Horner syndrome, will be a small pupil due to sympathetic nerve involvement. There is involvement with Horner syndrome and with Ehlers palsy, the phrenic nerve paralysis association. This image to the right, Klumpke's palsy, there is lower trunk injury, C8, C7, 8, and T1. Klumpke's palsy occurs in the adults due to overstretch of the hand. And during infant, there is hand presentation and with shoulder dystocia. Prevention of shoulder dystocia by identification of risk factor and early treatment. By diagnosis and optimal control of gestation and insulin-dependent diabetes, reduction of maternal obesity, careful plan for mode of delivery in women with past history of shoulder dystocia. Recurrence rate is 10 to 15%. So the delivery will be at hospital in well-prepared, well-equipped hospital for emergency section and blood bank and with expertise personnel. Prediction: presence of risk factor of macrosomia and by ultrasonographic assessment of fetal weight. So the dystocia neither could be predicted accurately nor could be prevented entirely. Can occur in a normal birth weight. Diagnosis: definite recoil of the fetal head back against the perineum, which is called turtleneck sign. Like a turtle, the head after delivery will be regressed into the perineum between contraction. During contraction will be pushed and in between will be regressed into perineum. Inadequate spontaneous restitution will be hanging of the head and incomplete restitution will occur. Fetal face becomes plethoric due to stagnation of blood. Failure of shoulder to descend. By one of these, we'll suspect shoulder dystocia and will confirm by gentle axial traction. If gentle axial traction fails, this will confirm shoulder dystocia. So first, call for help. It's an obstetric emergency. First, call for senior obstetrician for additional staff. Call for midwives. Call anesthetist, neurologist. Inform the blood bank and alert the theater. This is an additional maneuver will aid in delivery of the fetal shoulders. First, any maneuver not more than 30 seconds due to any head-shoulder delivery interval more than 5 to 7 minutes will associated with permanent neurological dysfunction. So, any maneuver not more than 30 seconds. These are additional obstetric maneuvers aid in the delivery of the shoulders and trunk. It's classified as simple first line measures, second line measures, and third line measures. Simple first line measures first start what we call McRobert maneuver. If failed, after 30 seconds, we'll add suprapubic pressure. Second line measures, which is called internal manipulation, will start with removal of the posterior arm. 30 seconds. If failed, we'll start with rotatory internal maneuvers. And rotatory internal maneuvers are Robin 2 maneuver. If failed, we'll add with screw. If failed, after 30 seconds, we'll shift to reverse with screw. If this rotatory internal maneuver failed, roll the patient on 4, which is called gasket maneuver. If failed, this third line maneuver, which is called last resort, the vanilla maneuver, symphysotomy, and cledotomy. We'll explain all of these in details. Simple first line measures start with McRobert maneuver. In McRobert maneuver, there is hyperflexion of the maternal hip with abduction and external rotation. This position. During second stage of labor, there is lateral position. Tamam? But if there is shoulder dystocia and we'll add McRobert maneuver, there will be hyperflexion, abduction, and external rotation of the thigh at hip joint. This is called McRobert maneuver. McRobert will straighten the lumbosacral angle and increase the anterior posterior diameter of the pelvis and simultaneously flex the fetal spine. احنا قلنا الدليفري of the fetal trunk by lateral flexion. تمام؟ فهو will aid in the flexion of the fetal spine. The simplicity of the McRobert maneuver and proven effectiveness, which will reach 42%, will make it ideal first step in management. When suspect shoulder dystocia, do gentle axial traction, then confirm shoulder dystocia. After call for help, start with McRobert maneuver. Suprapubic pressure. An assistant should attempt external manual suprapubic pressure on maternal abdomen for no longer than 30 seconds, while the delivering provider continues gentle axial traction. Will be done by an assistant. And one doctor will continue in gentle axial traction every 30 seconds. If the fetal shoulder is delivered, will be successful maneuver and resuscitate the baby. If it failed, we'll try the next maneuver rapidly. طيب. The assistant hands should be placed on the maternal suprapubic area over the fetus anterior shoulder. This image will explain this is anterior shoulder which is impacted. تمام؟ لأنه هو most common impaction في anterior shoulder. The assistant, one doctor will be in the head for dental axial traction, and the assistant will be in the abdominal for suprapubic pressure. The suprapubic pressure will be from the back of the baby. This is specifically posterior aspect of the anterior shoulder. The oxygen of the fetus will demarcate the back, and abdominally as suprapubic area will do the suprapubic pressure. McRobert maneuver and or suprapubic pressure relieve 58% of shoulder dystocia. It's add-on to McRobert maneuver. The maternal position is still in the McRobert maneuver and will add suprapubic pressure. Success rate will be 58%. Second line measures internal manipulations, which is start with posterior arm, removal of posterior arm, then internal rotatory maneuver, then roll the patient all in 4. It's 3 in the second line. Internal maneuver first, delivery of the posterior arm was shown to be the safest and the most effective. عشان كده نبدأ بيها في internal manipulation. As the posterior arm is removed from the birth canal, the bisacrimal diameter narrows, resulting in 20% reduction in the shoulder diameter. This allows anterior shoulder to collapse as the fetus descends into the pelvic hollow, which frees the impaction anteriorly. By delivery of the posterior arm, the fetal trunk will drop in the pelvic hollow and the anterior shoulder will be disimpacted. This demonstration of posterior arm removal to prevent unwanted fracture and dislocation. Insert two fingers along the ventral artery of the fetus and press antecubital fossa. Then raise the antecubital fossa and press it. When pressed, antecubital fossa will be flexion of the elbow. To maintain this flexion, grasp the wrist by index and middle finger and deliver the hand across the chest. After 6 seconds, if delivery posterior arm fail, start rotatory interior maneuver. These maneuvers attempt to manipulate the fetus to rotate the anterior shoulder into an oblique plane and to disembowel the anterior shoulder by escaping the symphysis. This can be accomplished by Robin 2 maneuver, wood screw maneuver, and reverse wood screw. First, Robin 2 maneuver consists of inserting the first two fingers of one hand vaginally behind anterior fetal shoulder and pushing the shoulder anteriorly towards the fetal chest. This pressure will adduct or collapse the fetal shoulder girdle and reduce its diameter. In Robin 2 maneuver, insert two fingers vaginally and try to raise the posterior aspect of the anterior shoulder and press. By this, either you collapse and reduce the bisacrum diameter or dislodge the anterior shoulder from the symphysis pubis and will be an oblique line. This will aid in delivery of the fetal shoulders by gentle axial traction. If failed, go to the next maneuver. So, Robin 2 is similar to suprapubic pressure, but suprapubic pressure is abdominal and Robin 2 maneuver vaginally, both of which add posterior aspect of the anterior shoulder, its impacted shoulder, either abdominal by suprapubic pressure or vaginally by Robin 2 maneuver. Wood screw maneuver. Wood screw approach the posterior shoulder from front of the fetus and rotate the shoulder towards the symphysis in the same rotatory direction with Robin 2 maneuver. Earlier, we introduced the first two fingers for Robin 2 as the fetal back, tamam? In wood screw, in addition to first two fingers at posterior aspect of the anterior shoulder, we'll add two fingers in the ventral aspect or the fetal chest. This is Robin 2 and this is wood screw. In Robin 2, the doctor will insert two fingers, try to reach the posterior aspect of anterior shoulder. This is anterior shoulder and this is posterior one. Try to raise the posterior aspect of this shoulder and rotate to change the diameter from anterior posterior to oblique diameter. In wood screw, this is two fingers inside posterior aspect of the anterior shoulder and add another two fingers in the anterior aspect of the posterior shoulder. By this, we will also change the diameter from the anterior posterior diameter to an oblique one. If wood screw maneuver after 30 seconds fail to deliver the baby by gentle axial traction, we'll start reverse wood screw maneuver. In reverse wood screw, try to reach the posterior aspect of the posterior shoulder. In reverse wood screw, this image represents reverse wood screw. This is anterior shoulder and this is posterior one. In reverse wood screw, we'll try to reach the posterior aspect of the posterior shoulder and reverse the direction of rotation. In wood screw will be directed anti-clockwise and in reverse wood screw will directed clockwise. We revise the direction of rotation. Also aiming to change the diameter from anterior posterior to oblique diameter. All internal rotatory maneuver have the same mechanism. In reverse wood screw, after the hand is in place, the provider or the doctor may attempt to rotate the fetus in the opposite direction as the wood screw maneuver. This rotates the fetal shoulders out of the impacted position and into an oblique plane from which they can deliver. This figure demonstrates Robin 2 and wood screw and reverse wood screw, all the internal rotatory maneuver. Third maneuver in internal manipulation is roll the patient, all gasket or all four maneuver. So it inserts mother to be in knees and rest position. This occurs mainly in community-based situation for the slim mother without an epidural. The fetal shoulders often dislodge during the act of turning from supine to all fours position, and the gravity will aid in releasing the impacted fetal shoulder. In this position, first try gentle axial traction. If failed, repeat all of the internal rotator maneuver layer open 2 with the screw and reverse with the screw in this position. If failed, they will be the last resort اللي هي third line measures. Third line measures. First, the vanilla maneuver. The vanilla requires reversal of the cardinal movement of the lever. هعمل دي restitution, flexion and subsequent manual replacement of the fetal vertex into vaginal canal, followed by cesarean section. The vanilla hits cesarean delivery after reversal of the cardinal movement. Symphysotomy هو intentional division of the fibrous cartilage of the symphysis pubis under local anesthesia. Women who undergo this procedure might experience chronic symphysial pain due to separation and could potentially have urethral trauma. Deliberate clavicular fracture or crizostomy. Clavicular fracture with a live fetus اللي هي بتكون direct upward pressure on the mid portion of the fetal clavicle or even form crizostomy. form crizostomy by scissors، لكن الكلافيكر بتكون للديد fetus. أما الألايف fetus بيعملوا clavicular fracture بالبريشر. البريشر بيكون في الميد portion of the clavicle to avoid the subclavian results. طيب الكليدوتومي with scissors result in fracture and reduce the shoulder diameter. Both will reduce the bisacromial diameter. This maneuver increases the risk of injury of the fetal subclavian vessels and lung tissue. Will be the last resort. After delivery, postpartum hemorrhage and significant maternal trauma associated with shoulder dystocia. نعمل examination to the mother نشوف perineal trauma and guard against postpartum hemorrhage. The baby should always be carefully examined by neonatologist لأنه قلنا فيه the commonest complication is palsy. Explanation of events is essential for the mother and her partner and counsel her about risk of recurrence. Documentation. Not forget documentation in any obstetric emergency. Documentation for date and time. Staff attending at delivery of the head. Additional staff attend for delivery of the shoulder. Which shoulder was impacted, anterior or posterior? Which maneuvers used? Which one is successful for delivery of the shoulder? The fetal status, the neonatal status at time of delivery, and neonatologist assessment after delivery. Thank you.